So in January of 2021, price transparency in healthcare was supposed to be a real thing. It was a rule that was passed during the Trump administration. Originally, it was part of the Affordable Care Act, Obamacare, which, hospitals and the healthcare industry, the insurance industry, absolutely loved. But they apparently didn't love the aspect of it to pass along the information of price transparency. They wanted to keep that hidden. So finally, during the Trump administration, this was supposed to be real. It was supposed to be out there. It was supposed to be published. Two Georgia hospitals last week were hit with federal financial penalties for failing to disclose their prices, marking the first such enforcement action taken under federal rules that have met with uneven compliance since taking effect in January 21. Here to give us some insight onto this is Paul Seegert, who's managing partner with PCS Advisors. PCS Advisors, a health benefits consulting firm with 35 partner offices across the nation. Paul, good morning. Welcome back to the program. How are you, sir?
I'm doing great. How are you today?
I'm doing fine. Now, look, we've got hospitals here in our area, just like all over the nation, that are not complying to the price transparency rule.
Well, yep, and that it's more likely that is the case than not. If you look at the three largest chains in this country, HCA, Common Spirit Health, and Ascension, 0.5% of their locations are in full compliance with the rule, which requires that you publish two prices, one price lists, a comprehensive list, and then a list that's more interactive and shoppable, so to speak. And by and large, as an industry, this has just been ignored.
Yeah. And there's creative ways around it, from what I'm told, too. But what we've got to get to, Paul, is just like when you walk into a restaurant, you can see what the price is. Well, most restaurants anyway. You can see what the price is before ordering, so you can decide if you want to add bacon, if you want to add cheese, if you would rather not get the hamburger, you'd rather just get some chicken nuggets, whatever you decide, because it's based on what you want and the prices that you see. But you can't do that when it comes to healthcare.
No, that's really one of the biggest challenges we face, is that you have this powerful force, the American consumer, and we don't give them information to consume well in our normal model. You get to know what your copay is, maybe what your deductible, your max out-of-pocket, whatever your share of cost is according to your insurance plan. Mm-hmm. But that has no relation many times to the actual cost of care. Mm-hmm. And you can have, and just as importantly, we don't share quality information easily. So you could be a consumer. I just had I'm a real-life example of this. I had a hernia repair surgery 2 weeks ago, and the price for that, if you're a cash payer, you could go in and get that procedure done by one of the best surgeons in this region, all in at a surgery center for single digits, thousands of dollars. Or you could have an insurance plan that could pay $30,000, $40,000, $50,000. You don't have any idea. And with the plans designed the way they are now, where more and more share of cost keeps getting shifted to consumers, even if you're not a cash payer, cost matters. Mm. I mean, you've got a huge risk. These Affordable Care Act plans now, we were just looking at the upcoming year, and the plan designs will allow for $9,100 out-of-pocket max for an individual, twice that for a family. That's an incredible amount of money. Mm-hmm. To be able to have at risk and not have the information to consume effectively. It's really ridiculous.
Yeah. And where are the hospital associations on this?
Well, they of course are working on behalf of hospitals, so you're not going to hear a ton out of them on this matter. And hospitals, I've had the chance to work with some hospital associations around the country, and in what I do, and the challenge is, in their business model, it's not uncommon for a hospital to have more than 150 prices for one procedure. Now, they have so many different contracts with so many different payers, insurance companies, and so on.
Yeah.
it can be a really wild range. I mean, I was looking at what was considered a minor heart procedure at a facility, and this happened to be in California, but it could be anywhere. Mm-hmm. And depending on your health plan, it could cost, total billed amount could be anywhere from $80,000 to $540,000. You could have the same surgeon in the same room doing the same procedure. There's a huge variation, which is something we really need to address, which this rule was, I think, a good first step in doing, so long as we actually enforce it.
Yeah. This is just unbelievable. I mean, we don't apply this to anything else in the market. Nothing. I mean, going back to buying a hamburger. If my 16-year-old son goes to the burger joint and says, "What's the price of the burger?" It's not different for him than it is for the guy driving a Cadillac that comes in after him. It's not different for him if I'm paying for it as his provider than it would be if he pulled out the cash he made from mowing lawns. I mean, how did we get to this point, Paul? Why is this so screwed up? What difference does it make whether I have insurance or not, and who the insurance company is? Why isn't a procedure based upon the cost of that procedure?
You know, that's where we need to get, and I absolutely agree. And another point or element that kind of illustrates this point of inequity that we have in our system is there's two things that come to mind. One is, if you're a cash payer, we're talking around the country, it's quite common that it could result in an 80 to 85% discount off of what you're going to pay if you have insurance. That doesn't make a ton of sense.
No.
And then the other issue I see with our system as it is today is that you have, really, when you look at a hospital, which is what this rule's about, you've got three kind of big groups of payers that come in. If you come in and you have Medicaid or Medicare, those hospitals very likely will lose money on that procedure. They might need 118, 120% of what they collect before they break even. And then you have these jumbo employer plans that have smart consultants involved that might have an employee or their family member show up that might end up paying cost plus a reasonable amount of profit. And then you have everyone else that shows up that has insurance that might be in a small group plan or an individual plan or a Obamacare exchange plan, and they don't have really anybody watching what's happening there, and they might pay 3.5, 10, 12x what those other payers pay.
Yeah.
So you have this massive inequity in the system. So when people come through and say, well, shoot, it would all be cheaper if we were all on, say, Medicaid or Medicare. Well, that sounds good, but in the current model, Medicare survives because others overpay.
That's exactly it.
You don't have a fair system. If we all paid about 145% of what Medicare pays, everyone could make money on the provider side. Now, some of them might have to take a little bit of a haircut, but they'd make a living and a good one. And then we could all know in advance when we walk in, just like when we buy a car, this is what it costs, and we could actually negotiate effectively.
Yeah.
Doesn't sound that crazy. It kind of sounds like free market forces to me.
It's unbelievable. I don't know how we ever get there. We need to get the government out of it, number one. The government has to be out of this. And really, it's shame on the insurance companies for going along with this stuff. They are a major part of the problem when they joined in with Obamacare. That's
a fact. As a matter of fact, the intervention into the system with the Affordable Care Act, more people are covered today, but that's through expansion of subsidies, and it's the least efficient way to pay for coverage. We're paying $20,000 per person we put on health care when the government pays. And when we changed the rules of the game, we took away an ally. I mean, insurance companies are often the villain. I understand that. But when you look at what happened 11, 12 years ago when the Affordable Care Act kicked in, we told insurers, hey, as long as you spend 85 cents for every dollar you get from this client, you can keep the balance. They're in a cost-plus model now. We turn them into like a utility or something. They do better when claims costs go up. So who is supposed to be watching the hospitals like we're talking about today? Mm-hmm. If an insurance company just, in simple terms, does better if the hospital charges more, but they're the ones that are going out and negotiating on behalf of all these payers out in the market. We don't have an ally anymore, and it's not a single variable equation. You have these insurance companies going to consumers and employers and so on that they represent, saying, "Hey, look at my deep discount. Maybe I have a 65% discount or 70% discount, but let's talk about what number you're going to apply the discount to. I mean, if you're going to 10 or 12x that number before you apply it, am I really getting a discount?"
Yeah, right.
And we're not having that conversation.
No, of course not. People need to understand, if you work for a large corporation, you've got, you can brag about, this great insurance package that you have. You are not the insurance company's customer. Your employer is the customer. You are simply a number, and that's all you are.
That's a fact. And if employers are waking up, I think the silver lining of this whole thing, or the optimistic part of this conversation that I get to have, is the fact that employers who have a balance sheet that they have to make work, who can't just print more money when they run out, these employers are the ones that are going to fix the payment model, I think, in healthcare in this country. And I don't think it. I know it. I'm seeing it every day. But you have employers, and it's coming down market in terms of employer size. You could be an employer with 50 people. You could be an employer with 100 people, 500 people, 1,000 people. So these are not massive employers in this country. But you now can be an employer at that size. And with the right guidance, you can eliminate a lot of this waste in the system and get healthcare to where it's more affordable. There's examples all around the country of employers who've cut the cost of healthcare for their employees in half and have not sacrificed one bit of quality in the process, even improved it.
Interesting. All right, and you can probably give some more information on that with PCS Advisors.
You certainly can. We're happy to help if we can, but most importantly, I think we just need to, as a country, we have to address this and keep talking about transparency. If you could put it into one word, what do we need more of? It is transparency.
Yeah, absolutely. So these two Georgia hospitals last week that were hit with these federal penalties, you think that's going to have any reverberation around the country?
Well, I think certainly people are paying attention in the industry. But when you start to learn about the numbers involved, it's $1 trillion going through these hospitals. And the fines up until January this year, the maximum fine was $300 a day, about $110,000. That is not even a rounding error for a lot of these hospitals. So it wasn't a real shock that compliance didn't become a real big thing. I mean, if you pass a rule and you have a nice press event, but then you tell the hospital that it's going to be a $300 a day fine for noncompliance, it might be more expensive to comply. And so it didn't have teeth. And then January 1 of this year, they upped that to a max of $2 million. Certainly sounds like a much bigger number, and it is. But we're talking about a mid-sized hospital that could have north of $10 billion in billing. So is it a significant number to them? For many hospitals, it still will not be. So I think we're going to need folks like yourself in the marketplace that are also putting a spotlight on this, where they get attention for the noncompliance. Yeah.
What about certificate of need? Our West Virginia legislature failed to repeal that. Is that something that could help as far as more competition? Because right now we have a monopoly with the hospitals buying up all the local doctors.
Yeah, that's been a challenge in our industry for a long time, a growing challenge where you have less and less competition. Ironically, that also, the Affordable Care Act affected that, where they didn't allow physicians. One of the ways physicians could kind of combat that would be to band together and start their own facilities, have physician-owned hospitals, like you have physician-owned outpatient surgery centers today that often outperform hospitals and outcomes and at a lower cost. And we need competition is certainly an element of what we need more of. And the Affordable Care Act said no more physician-owned hospitals. Those that existed were basically grandfathered in, and you couldn't get more. And there is some talk of changing that, which I think could be also a positive move.
All right, let's hope so. Let's hope so. Well, I mean, in your opinion, just real quick, Paul, does certificate of need to be repealed in West Virginia?
I would say it's certainly worth considering.
Yeah.
And very well could help.
All right, Paul Seegert, a managing partner with PCS Advisors. Paul, thanks so much for your insight. I appreciate it.